Hello, everyone. Thank you for joining us for this presentation today. My name is Dr. Avi Cohen. I'm one of the interventional pulmonologists at Henry Ford Hospital in Detroit. I'm the director of the Advanced Therapeutic Bronchoscopy Program here, and we've been building a very strong bronchoscopic lung volume reduction program. So with that in mind, I'd like to present today optimizing a Zephyr Valve Program efficiency and identifying the roadblocks to patient treatments. I do have one disclosure. I am a consultant for Pulmonx. So Henry Ford has had quite a long journey in terms of being able to build this big and robust program. When the valves were first approved in 2018 by the FDA, we jumped on this opportunity right away, and we started to build up the protocols and expect what we would do and need to do to become the best program in the country. And as we were able to slowly come together and put our heads together, we finally had a strong protocol in place, and we treated our first patient in April 2019. As of the last week, we've treated 389 patients, and obviously because we screened so many, 1,013, we've been able to include so many patients to undergo this procedure. So when you're looking at starting a program, the first big thing you want to think about the 10,000-foot view is what is the goals of the programs. And when you're thinking about BLVR programs, what kind of patients are you treating? What are the clinical outcomes that you're trying to achieve with this BLVR program? How do you minimize that time from referral to treatment? You don't want these patients waiting in queue for months on end, wondering when they're going to get a phone call and when the procedure would be scheduled, when they'll be meeting with their physicians or advanced practitioners. And biggest goal, I think, is you want to minimize the number of clinic visits. You want to be as efficient for both yourself and the patient together. So when you're thinking of these goals, you got to start thinking of what constraints and barriers come to mind. The obvious one is physician time. This isn't the only thing that you're doing as a physician. There's more to it than just BLVR for a pulmonologist. So your time has to be allocated appropriately. Not only you, but you have a lot of help that comes along with you. The advanced practitioner providers, the APP's time is also very important. And nothing could be done without a strong coordinator. A coordinator will be able to coordinate some of the logistics, freeing your mental bandwidth to do what you do best, your clinical work. The procedure needs to be done in a specialized room, or even not a specialized room, endoscopy suite, for example. So availability of those rooms can be a big constraint. And because they undergo general anesthesia or in rare circumstances, moderate sedation, the availability of anesthesia is important as a constraint to achieving your goal. And then finally, after the procedure is done, what are your resources that are available for recovery? What are your resources after their discharge from the hospital and the follow-up appointments and thus far? So looking at your goals and constraints and trying to get the best efficient program in place. Now, how do you define efficiency? Efficiency is you want the maximum amount of desired output, which is your numerator, with the minimal amount of resources that you're going in to invest to get that output. So when it comes to bronchoscopic lung volume reduction, your desired output is how many patients you're treating. And the resources that go into a program is your physician time and effort, your APP and coordinator time and effort, your hospital financial resources, and your staff time and effort. You want to maximize your patients treated, and you want to minimize or make as efficient as possible the resources going in. So let's look at some barriers that could come to mind when you're starting a program as to how you could allocate the proper resources. When we started our program, these are some of the biggest barriers that we've run into. And when we were starting the program, I wish there was someone who could have told me that this is coming to mind so I could be better prepared for it. The biggest barrier is your administration. Without the administration support, you're not going to have that foundation to help you evolve and project to where you need to be in terms of a large program. You need to see these patients in clinic. So clinic space is a big one. We've commonly come to realize that yes, we can see 20 patients a day. Of those 20, perhaps 6 are BLVR. But when they come to clinic, there's more to it than just sitting down and talking to them. You need to do a complete pulmonary function testing that requires resources in terms of respiratory therapists, body plethysmography. So with that clinic space comes a lot of the testing that need to be available. Doing the procedure requires an allocated time. This isn't a short procedure. It can take somewhere between 30 to 45 minutes, depending on the degree of experience. And you want to do it as frequently as possible, so you immerse yourself and you have this nice, well-oiled machine that you're constantly able to treat patients without trying to guess when your next available date would be, but being very consistent as to every day, which day, and how far ahead you can have it. So we really worked hard to secure our procedure time at Henry Ford. And we've been lucky enough to have the administrative support behind us to do that. After the procedure is done, these patients require an inpatient hospitalization for monitoring of adverse effects. So getting buy-in from your staff to be prepared for this patient population. For us, we did a lot to reach out to the nursing staff in the intensive care unit when we first admitted these patients, to the nursing administrators. We did a lot of education, so everyone is well aware of what this novel procedure is, so no one feels like they're jumping into the deep end without any idea of how deep it is. So our nursing education took place, the intensive care unit, the general medicine unit, all were participating in all the different programs that we put on for the staff and everyone else. So getting the nursing on board, getting the social workers, the case managers, the physical therapists, and getting them really involved in anticipating what this patient population is like will make it very easy for them to care for these patients and more enthusiastic to do so. Now, these patients can have a complication that can occur at any point. It can happen during the day. It could happen at night. During the day, our specialty interventional pulmonology is available and we can easily intervene. At night, it requires us to drive in. So sometimes complications can happen pretty quickly and require immediate attention. So it's important to make sure that you have provider coverage overnight. In some cases, you have intensivists that are working 24/7 shift-based, like nocturnists, for example, who are capable of doing the procedures that are necessary for complications, namely pneumothoraces and chest tubes. So at Henry Ford, we were able to utilize our nocturnist, and we educated them on what the risk profile of the pneumothorax is, and all of them were uptrained in performing pigtail catheters or small bore chest tubes, and so they were on board, and there wasn't any hesitations on taking care of these patients and providing the best care for these patients. In some hospitals, you have surgical services that are available, and something to think about. Surgical chest tubes can be larger bore versus smaller bore. Some places have IR, interventional radiology, that are available 24/7 to put that. So keep that in mind when you're designing your program. How are you going to cover this patients afterwards? So we for our program, because the pneumothorax can happen so rapidly and requires rapid intervention, supplies are important. So we created a pneumothorax cart that we would put at bedside with the patient to care to be um, to access the resources as quickly as possible. So those added up, the cost of the pneumothorax kits, and we didn't quite anticipate what an impact it would have on the financial aspect of the program. So things to think about: what is the cost and availability of your pneumothorax supplies, and how are you going to do so? Now, a lot of these patients have emphysema, COPD. They're at high risk of developing lung cancer, so nodules are frequently found in this patient population. That came to light for me when I was screening a lot of these patients, looking at their CTs, and these new nodules popping left and right. So we created a nodule protocol. It's one barrier to think about. That nodule protocol gives us a consistent and standardized approach on when we should do surveillance, when we should consider a nodule benign based on radiographic stability, for example, from the Fleshner criteria, and when should we consider tissue acquisition. So don't forget that beyond BLVR, these patients are at high risk of lung cancer development, and having a strong workflow on how to manage these nodules that come up pretty frequently will minimize the amount of resources you're investing in these patients, or I should say optimizing the amount of resources you're investing in these patients. Um, education is a big thing. This is BLVR is fairly a robust procedure that requires a lot of education for the patient to understand what the outcomes are, the complication rates are. And we found ourselves spending maybe an hour block at clinic going over what BLVR is, showing them the valves, showing them what a pneumothorax looks like, and explaining how a chest tube goes in and how it feels if it goes in, and if it is painful or not, and what we do to mitigate pain. What is the risk of pneumothoraces? That's very important. Education of what to anticipate in terms of a risk, even when it's high as 20% for pneumothorax, is extremely important. So one thing we did is we reduced that resource in terms of spending face-to-face time with the patient, and we created a video that educates patients on what BLVR is. And every physician may have a certain degree of education they want to imprint upon the patient. And so making your own video, so that way the patient meets the physician virtually on a video before they meet you in person, really cut down our time that we needed to go over the valves. So we send these videos to these patients, they view the video, and once they're done, they come to clinic. We ask them, did you watch the video? And they said, yes. Do you have any questions? A lot of the times they say, no, I completely understand. And then we do a teach back method to ensure that they did understand the video and fill in the gaps, the knowledge gaps that they might have not acquired from just watching the video. So that cut our clinic time in 30 minutes by 30 minutes, a good amount of education that we were able to digitalize as a barrier. Insurance authorization and appeal letters. We often run into different insurance companies that are perhaps not well versed in the procedure and don't realize the necessity, the medical necessity of these patients being admitted for potential complications after the procedure. So we designed a template for a letter of medical necessity that clearly states the research behind it and why this patient needs hospitalization. We educated our coordinators on immediately identifying the insurance companies that were at high risk of rejecting due to authorization requirements, and preparing that letter to send to them, and following up accordingly to ensure that that appeal goes through or not. So there's a lot of behind the scenes that takes place with the coordinator that reduces that barrier as well. And then going on nodules, abnormal patient findings. Those are all different things that we notice on CTs, and this is an elective procedure. You never want to put a patient through an elective procedure if there's a life-threatening or a life-compromising finding that requires further workup. So any abnormal findings at Henry Ford, a physician will briefly review it, and we generate a letter that goes up to the referring physicians to continue evaluating that, whether that referring physician is a primary care physician or another pulmonologist who's interested in having their patients having this procedure done. So a lot of barriers, a lot of things to think about when you're designing a program. And it's important to look at your program and see where your bottlenecks are and attack those barriers before you launch, so you can launch as efficiently as possible. So there are different ways to do this, and I'm going to show you two different workup processes that take place. On the top, there's program number 1. On the bottom, there's program number 2. If you look at program number 1, we'll start with program number 2. And program number 2, which is more conventional for a referral process for a tertiary center that's evaluating a patient for a certain disease that requires a subspecialty or even a specialty. The patient is made an appointment and they meet in clinic with a physician. The physician is reviewing the case that the day before or the day of the clinic and deciding, okay, this patient was referred to me for, in this example, bronchoscopic lung volume reduction. I'm going to need a workup. My workups are pulmonary function testing, 6-minute walk test, and let's see if they meet the inclusion criteria for BLVR. Those testings are done. They return to the clinic with the physician. You go over the testing, and you decide, for example, this patient is a good candidate to undergo bronchoscopic lung volume reduction. Great, let's move forward now. Let's do the high resolution CT that's necessary, the ABG, the echocardiogram, the perfusion scan that might be necessary. So additional testing to go past what needs to be done to confirm inclusion or potential benefit from BLVR. The testing is done again on a separate day, and then they come back to the physician. The physician goes over the testing with the patient, reviews all that, says, yes, you're a great candidate. Let's get you scheduled for the procedure. The procedure is scheduled, and they undergo the valve. So this is what I would call a more inefficient workup process. They're meeting a physician 3 times. A physician's clinical bandwidth can be better allocated doing other things. And so if it's for testing, for example, these are things that could be more efficiently done by other individuals or ancillary staff. So up here you have program 1, where you have your APP, which is either a respiratory therapist, a nurse, a physician assistant, or a nurse practitioner. They get a referral for BLVR. They review that referral and they decide, yes, this would be worth looking into. So they create a virtual visit. They meet with that patient virtually. They talk about why you're here, why you were referred. They talk about bronchoscopic lung volume reduction. And then they move forward to ordering the tests. And all of the tests are done together. The PFTs, the ABGs, the high resolution CT, the echocardiogram, the 6-minute walk test, and the SPEC study, all in one test. All of this is then reviewed, and then you create another meeting where you meet with the APP again, or the physician at this point. You have all the information you need, and then you could move forward to doing the procedure. Or you could have a multidisciplinary review without meeting with the patient. You review all this information, have the clinic visit, and move on to the procedure. Here in this program up here, the logistical lifting is done by who does it best, a coordinator, for example, or a nurse practitioner who can discuss the case with the patient. So the physician has more bandwidth to do other things that they're great at, and better able to take care of more patients that way. And then from the side of the patient, you minimize the number of visits they need to have. In this case, you have basically one clinic visit, whereas they virtually visit, they have the testing done, you review the testing, and then you invite them to the clinic visit to have the procedure, discuss the procedure, and have the procedure. So in order to be able to do all this, as you can see, there's a lot of resources going into this, a lot of people going into this. So you need to build a strong BLVR team. So what we like to say is, you've got a program coordinator in the center of this, and the program coordinator of the BLVR is able to bring together all the different interdisciplinary resources to decide if the patient needs a bronchoscopic lung volume reduction. So who's part of the team? You have the interventional pulmonology team. That's the main contact. Those are the patients who will take accountability for, those are the main people who take accountability for the patient, start the workup, and do the procedure. Radiology, they have a big involvement in this. They're the ones who are performing the CTs, the VQ scans, if there's quantitative studies done. It's important. For example, at Henry Ford, we've allocated a day where radiology already knows that we're going to put in 3 patients at minimum to do these CT scans. So it's blocked off and they're ready. And we know exactly what day it is, at what time it is, and we offer that to our patients. You have your ancillary staff in terms of respiratory therapists, your pulmonary rehab, your PFT labs. We get allocated times for that. You have the procedure team, the nursing team, who manages the patients after the procedure and during the procedure as well. You have thoracic surgery if there are certain collaborations that need to be done. For example, if they're better candidates for burlectomy, for example. And from the other side, the thoracic surgeons themselves, when you have a strong collaborative team, will refer patients to you when they're referred to them for burlectomy, and they believe that bronchoscopic lung volume reduction would be better suited. You have the team that works behind the scenes for the admission and reimbursement. We have what's called a transfer team and a authorization team that looks into prior authorization, the billing and coding, and helps us optimize that. You have your clinical team, and then you have your referring physicians. So with all that, I want to talk more about our program at Henry Ford, and I can attest to what made us so successful. And perhaps you can take a lot of what we're doing and instill it into your program to improve and get your success as powerful as possible. So at Henry Ford, our criteria is slightly different. We do our complete pulmonary function testing. We expect an FEV1 between 15 to 50% with an RV of above 150 and a total lung capacity above 100%. Their 6-minute walk distance has to be between 100 meters to 500 meters. Their echocardiograms should be free of signs of pulmonary hypertension. Their arterial blood gas should not show severe hypercapnic respiratory failure. They obviously have to be smoke-free for 4 months, and they shouldn't have any pulmonary nodules that are suspicious for malignancy. And stability, radiographic stability for over 2 years is oftentimes enough to do so. So with all that in mind, I want to talk more about the Henry Ford patient pathway. This is a little bit of a busy slide, and I want to go over it in 3 separate buckets. This left side is the intake bucket, the middle side is the testing workup bucket, and then on the left side is the procedure itself. So from the intake standpoint, you have the referral coming in, either externally, it's a patient that is already known to Henry Ford, or internally presented to us from outside our general pulmonology or IP division. When that information is sent to us, our coordinator will do an intake, and she will make sure that all of this information is available to review. That information includes the pulmonary function test, the CT if they've had any, a 6-minute walk distance, their smoking history, their comorbidities, and any medical records that come with that. If any of these are missing with the referral, our coordinators will try to obtain that, and if it's never was done, she would ask the primary referring physician to obtain it and send it to us once it's available. So we have all the data to move forward into the testing bucket. Once all this information is reviewed and they meet the inclusion criteria that we've provided with our coordinators, we've gone from the intake bucket forward to the testing workup bucket. So Jill will take this patient now, confirm that they meet the inclusion criteria for bronchoscopic lung volume reduction. She will send me a request to perform these tests. She puts all of these tests as a signature that's sent to me through Epic. I receive these signatures in Epic, review them, make sure they're appropriate, and sign them. When I sign these, it orders a pulmonary function test, a 6-minute walk distance, a high resolution CT, an arterial blood gas, and an echocardiogram if these 2 were not done in the past. These 3 that are in purple are done at Henry Ford Health, and they're done the same day that the patient is coming in for an office visit. These 2 can be done outside of Henry Ford if they haven't been done, or they could be done at Henry Ford at the same day that the office visit is scheduled. So all of these orders are scheduled, they are done, and then the office visit begins. The office visit is performed. It's either done by an advanced practitioner or myself. We review all of this data the same day that it was obtained, as the patient we're discussing the procedure with the patient, and we let them know, hey, your data looks great. You're a great candidate to undergo bronchoscopic lung volume reduction. You're gonna gain from this, from what we're seeing. So let's move forward. So now the CT that is completed is uploaded to StratX, where it determines the target lobe and fissure integrity to see if they are a candidate. And sometimes we order a perfusion scan based on that StratX report. So the testing is done, same day as the office visit. We discuss the procedure. We tell them, yes, you're a great candidate. We're going to do a StratX report. It'll be available in about 5 days. We'll review it and we'll call you and let you know if you're a good candidate, and we'll proceed. Or we might find out that your StratX report suggests that you're not an ideal candidate. You may not benefit from this procedure, and we would just tell you and not move forward. Regardless of what we do, all this information is sent to the referring physician. So the referring physician is following us through all of this process to see where their patient is in the process. Once we determine based on the StratX that they're good candidates, the insurance authorization is obtained. The patient is given a date, and they're boarded to have the procedure done. So they sometimes will meet the physician for the first time at the procedure. They would meet the advanced provider, the advanced practitioner, the APP, the the physician assistant or the nurse practitioner the day of. That same nurse practitioner or PA will be joining us for the procedure for the continuity of care and report that's developed with the patient. And then we do the procedure. The physician does the procedure. They have their recovery. They have the post-procedure follow-up, the 45 days, 6 months, and 1 year. All of that information is sent back to the primary care physician. So as you can see in this pathway, the physician meets with the patient once, and that's the day of procedure. The APP meets with the physician before the procedure, and the coordinator coordinates all the testing that needs to be done to determine if the patient is eligible for bronchoscopic lung volume. In this way, the patient has 2 visits, 1 visit for the clinic and 1 visit for the procedure. And then following that is the 45-day, 6-month, and 1-year follow-up that we have. So this flow is far more efficient from our standpoint and allows us to get more patients in at the same time and exclude patients out when they're not good candidates for the procedure in the most efficient way possible. So we don't waste the patient's time and we utilize our time as best as possible. So this slide is basically a text imposition of what we just described, a text description of what I just went over. The patient is sent for a consultation. Our coordinator obtains all the pertinent records. The preclinic screening is completed. If they are candidates, they're scheduled for a clinic visit. If they're not candidates or more testing is necessary, we reach out to the primary care physician to complete that pre-testing or let them know that they're not candidates. They have that initial consultation in our clinic only if the patient meets the minimal requirements. And that minimal requirements again is related to the PFT, CT, 6-minute walk distance, smoking, and comorbidities. When they are scheduled for the clinic visit, first they have their CT done. They meet with us. We go over everything with them. We discuss the procedure with them. The CTs are uploaded to StratX. That takes about 3 to 5 days to run the testing necessary on it to determine if they are further eligible. The StratX report is reviewed. If there are candidates, we obtain insurance authorization with an appeal process if necessary. If there are not candidates, we inform the patient. The coordinator informs the patients that they're unfortunately not a candidate, and the primary care physician or referring physician. If they are candidates and we've gotten the authorization completed, the procedure is scheduled. The procedure takes place. They're admitted for 3 days minimum post-operatively to rule out any complications. After the procedure is completed, after they're discharged from the clinic, our coordinators will then schedule the 45-day, the 6-month, and the 1-year follow-up with a complete pulmonary function testing, which would include body pleth, 6-minute walk distance, and a chest X-ray or a CT, depending on the symptomology of the patient or outcomes on perioperative outcomes. So in summary, Henry Ford has been very successful at doing this, predominantly because we optimize our resources. Our resources being our coordinator, our advanced, our APPs, and our physicians. Everyone works at 100% capacity of what they're great at, good at, and do well at. And with that, that concludes my presentation. I really thank you for your attention, and go out there and take care of your patients as best as you can and do what you can. Thank you.